He is Dr. Dan Clrak, and he joins us here on Indiana in the Morning. Good morning to you. Glad you're here with us on this beautiful, beautiful morning. It's a sunny day out there. Why are we not out somewhere doing something fun?
We should be.
Yeah. Well, this is fun. This is fun. Dr. Dan Clrak joins us here this morning from the Indiana Regional Medical Center. Dr. Clrak, and he's a surgeon, of course, but he has a lot of hands, a lot of irons in the fire, if you will, and some of those hands are robotically led. Our visit presented by Marcus and Mack, voted best law firm and best personal injury lawyer 3 years in a row in the Best of Indiana County contest. Visit them online at marcusandmack.com. I want to talk about hernias with you this morning.
Right.
There are people walking around with hernias today that probably have been walking around with them for quite a while and just refusing to get them taken care of. I can handle it all by myself.
Right.
Don't need to.
Yeah, that's what they think until tragedy strikes.
Yeah.
And that bulge is, what's in that bulge is intestine. And that intestine can get strangulated, and then it becomes gangrenous. And then we're not talking robotic surgery. We're talking a big old-fashioned cut with bowel resection associated with it.
Yeah, it's if you've got that bulge, it's not supposed to be there.
Right.
Yeah, that means your intestine is not in the area where it needs to be.
Right.
So people do that. We know that, and some people think that it's just a minor annoyance. If I don't move in this way or don't move in that way, it's not going to bother me at all. But with robotic surgery, especially, but with the various remedies that are available to treat hernia, there's no need to do that.
Right. The recovery is a lot different nowadays. And I always tell people the benefit of robotics is that there's far less pain, and that includes with a hernia repair. I also say the downside of robotics is that they're far less pain because patients think they're recovered faster. We can't speed up the physiologic healing of the tissues. So people are up and out and walking, same day, very minimal discomfort with them, and then they think they're healed and they can do everything. And we have to reinforce it. You still have to give the body time to heal, but you're up doing normal activities, the next day.
Yeah, slowing down. You're not going to be swinging the golf club, though.
Right. Swinging golf club's one of the worst. Twisting and turning, swimming, swinging the golf club, because those exaggerated twists, I always tell people, if you think about it, we put the tissue back together. But if you do twisting and turning, that tissue's going like this, well, we just repaired. And that can cause it to tear through. The acute phase of healing is 6 weeks. That's when your body's putting all the fibrotic tissue across and healing that tissue. Until then, the only thing holding it together are our sutures.
Yeah. We had to go back and start, first of all, by defining what hernia is.
Right. Everybody thinks it's just a bulge. Well, the bulge is what's going through the hernia. A hernia is actually a hole in the muscle. And so there's a hole in the muscle that allows intestinal contents to protrude through that hole. And most commonly is a groin hernia, or what we call an inguinal hernia. And you get the bulge down by the groin. And that bulge can even extend down in men into the scrotum, and women down in the labia, that can extend down because that's where that canal goes to. And, the worst hernias we do are those patients who wait so long that, in men, the scrotum is massively enlarged. And it's massively enlarged because there's a lot of intestine down in there.
Yeah.
And that becomes a very complex hernia to fix when we could have fixed it a lot easier when it was a much smaller hernia. So you really should look at those hernias when they're smaller and not wait until they get to the size where they're causing you pain and discomfort all the time.
Are people generally aware that it is a hernia? When they come to you and they've got this problem, something really hurts down there. Do they come to you and you tell them what it is? And they go, really?
No, most people realize they have a hernia.
Yeah.
And they've just put it off like everybody. We're busy. Life is busy. You don't have time to get it fixed. And I understand that. We're all like that. But I encourage people to not wait until it's actually causing you a lot of pain. Because if it's causing you pain, that's when you're at risk for having to be in the ER with an emergency surgery.
Yeah. All right. So let's talk about what happens when you come in and you get that hernia repaired. Robotic surgery, obviously, we've been talking about that. That's the best of the courses of treatment.
Right. When you look at it, the old-fashioned repair is cutting you from the front. Just talk about groin hernias for now. You make a cut in the front, but the hernia goes between the layers of muscles. So it's between your external oblique and your internal oblique. So to get to the hernia from the front, we have to cut the external oblique in order to get to the hernia and fix it and then repair the external oblique muscle again. When we do it from the inside, either laparoscopic or robotically, we pull the hernia contents back in and then fix the hernia from inside without having to cut any muscles at all. You have 3 little dime-sized incisions, and so that's why there's far less pain and discomfort. With an open hernia repair, you had it for 2-3 months afterwards.
Yeah.
With the robotic hernia repair, I have patients walk in at 2 weeks and look like they never had surgery, and they tell me they never took pain medication. Now, some people do require some pain meds. It's still surgery, and we do supply a small little course of narcotics, but most people don't even get it filled because they have far less pain.
Yeah. The hospital stay, obviously, is much shorter with robotics.
Yeah, it's outpatient now. Even with open surgery, we send people home nowadays. We do some nerve blocks. Those nerve blocks wear off, pretty quick. So most groin hernias are outpatient, unless you're that person who has, the bowel really down in the scrotum and everything. It takes a lot to fix that. And then we have what we call the ventral hernias, and that's up in the middle of the abdomen. Umbilical hernias are considered ventral hernias, but most commonly ventral hernias are from prior surgery. So, if you have to have a big open surgery, you're at risk for getting future hernias.
When we think about hernia occurring in our lives, are there specific causes, whether they're dietary or overexertion, or what might cause a hernia?
Well, absolutely. There's 3 big risk factors with hernias: getting hernias and then getting a recurrent hernia after it's been fixed even. Number 1 is obesity. I always tell people we're born with one set of muscles. And as we get heavier and our stomach stretches more and more, those muscles don't get bigger or thicker. They get thinner and thinner and thinner, and then the muscles tear, and then you have a hernia. So if you come in and you're morbidly obese and you have a hernia and we fix it, we haven't taken away the cause of that. It's still under tension. It's still being stretched to the max. And so we fix it, and then people get recurrence, and then they say, "What'd you do, doc? You didn't fix me right." And, and we can't do better than God, and we can't repair you back to original equipment. And especially with morbid obesity, that still puts a lot of stress and strain even on our repairs. So there is data out there now that if somebody comes in with a very elevated BMI, morbidly obese, and they have this hernia that's not symptomatic, the best thing to do is to try to get them into a weight loss program, an organized weight loss program like we have at our weight management program at IRMC, to get the weight loss down before fixing the hernia. The other things that increase your risk of hernia are smoking. Smoking decreases oxygen tension to the tissues, and the tissue around the muscle called the fascia doesn't have great blood supply to begin with, so smoking decreases the oxygen to the fascia, that is the strength portion of the muscle, and as a result, if you're obese and smoker, you have 2 things going against you. And the third thing is diabetes. Out of control diabetes, again, affects blood flow to the tissues and everything else. So we like to get patients' diabetes under control before hernia repair nowadays as well. We like to see what we call the hemoglobin A1C, which is a measure of long-term control, down to about 7 or less. So we'll check that before hernia repairs as well. Get real conscientious on getting the diabetes under control. If somebody's a smoker, we try to get them a smoking cessation plan ahead of time. And I know that's tough because smoking is a tough thing to quit. It causes a lot of things we all know about, cancers and things like that, but it really decreases wound healing dramatically. That's why most plastic surgeons will not do plastic surgery if you're smoking. So.
Wow. Dr. Dan Clrak, our guest this morning, we're talking about hernia and hernia repair and robotic surgery and the role that it can play in really restoring you to a better lifestyle, the life that you could be living without that pain. And obviously you don't want to carry that pain with you. You've talked about the ramifications of letting a hernia go untreated. When it is in that smaller stage, the beginning stages, obviously getting that treated is paramount. As it gets worse and worse, you talked about the full major surgery that everybody wants to avoid.
Right. If we get to it in a smaller size, we can go in and robotically stitch it closed. We do use mesh for most hernias nowadays, and we've been using mesh in hernia repairs for over 30 years. So all these commercials from the lawyers about, oh, have you had hernia mesh and this and that? They name every possible complication you can have from a hernia repair with or without mesh. And so, recurrent hernias, mesh has actually been shown to drastically reduce recurrent hernias. Yet they use it in their ads to say, have you had a recurrent hernia with mesh? Well, mesh drastically reduces your risk of recurrence. If I can fix all hernias without mesh, I know how to. But if I had a hernia myself, I'd want to have mesh put in it. But we can fix them without mesh. They just have a much higher rate of coming back with that. But yeah, if we get in there small, we can do a suture repair. Even the complex abdominal hernias from prior surgery used to require a big incision. We used to have to reopen that incision, take all those small little hernias up and down that incision, make them into one big one, and reclose your whole abdomen. Well, that's like having another major open abdominal surgery. Nowadays, we can go from the side with 3 little incisions, go in with the robotics. We can go stitch that back closed from inside without any big incisions and reinforce it, and then put the mesh in as well, and really drastically reduce that. That used to be, a 5-day stay in the hospital. Most people go home now same day or stay overnight in the hospital.
If we were talking to Dr. Dan Clrak 10 years ago, before robotics had advanced to the stage at which it is now, and was available here at IRMC the way that it is now, would that Dr. Dan Clrak be amazed that a hospital such as Indiana Regional Medical Center is this advanced with robotic surgeries?
Well, yeah, I mean, since Indiana got the robot, it's advanced many things. It's not just this, but 10 years ago here, this wasn't offered. I've been here 7 years. The robot's been here about 9. So yeah, if you were talking 10 years ago to anybody in town here, this was not an option for you. You had the traditional old-fashioned repairs. Now, if you're talking to me 10 years ago, I've been doing robotics for 17 years now. So I would have been doing this 10 years ago.
Yeah. But to have it here in Indiana, it's such a great advantage. Number one, the availability of IRMC for people throughout the region is much different than if you're trying to squeeze your way into a Pittsburgh hospital or some other hospital facility. You're getting it here, but you're getting as well really top flight surgery.
Yeah, and it amazes me sometimes when people they come in and see us, and then they talk to family and they say, oh, you need to go into Pittsburgh. Then I find out later they went into Pittsburgh and they had a big open procedure when we could have done it minimally invasive robotically. So just because you're going into Pittsburgh does not mean you're getting the best. I was the first certified robotic general and colorectal surgeon in all of Western PA, long before anybody at the universities. As a matter of fact, I've proctored multiple chiefs of surgery around Pittsburgh and the region and across the country and even into Canada. So going into the university doesn't mean that you're always getting the best or latest. Some of those people do really great open surgery, and there are some really fantastic surgeons down there. I'm not going to say there isn't, but we can do the same great surgery with minimally invasive approach. And it's not a hernia, but there was recently a person who needed a right colon for a certain reason that was found at an appendectomy. They were referred to me, and they went into Pittsburgh, and they had a huge open operation for something I could have done robotically, and they would have been out the next day. So the availability of the advanced techniques, that's why I'm here. I came here to proctor. I've been a proctor for robotics for 16 years. I've been doing robotics for 17 years. I've traveled all over the country teaching robotics. When I came here, what people don't realize, and you've heard me say it before, the facilities here are outstanding. They rank up there against the best in the country that I've ever seen. About 10 years ago or a little more, they did a $50 million renovation of the operating rooms, the intensive care units, the recovery room, and everything else. And when I came here to proctor for the robotics, when they were starting the program, I was just amazed at the whole OR setup, the ICU setup, and everything else. And when I always say Steve Wolf sat down and asked me, what would it take to have you come here? I said, you've already got it. With these ORs are state of the art, and that's what attracts talent. And it's there's been a lot more since me that have come because of the ORs, because of the facilities at IRMC, and because of the other doctors and support services that they have recruited in the interim, too.
We're out of time, as always. It works that way when we get talking with Dr. Clrak, because there's so much to cover, and we do it and enjoy so much the conversations that we have with you. Don't walk around with that hernia. Get it fixed.
That's right.
Get it fixed.
Yeah, come see us early. You know, it's an outpatient procedure, in and out, same day. You're up on your feet the next day, walking around, driving, stairs are fine. You know, so if we can fix it when it's small, much easier recovery.
Dr. Clrak, thank you.
All right, thanks.
It's Indiana in the Morning.